So, good evening. It's my pleasure to welcome you all to AusCADASIL's second webinar, which is being co-hosted by the Centre for Healthy Brain Aging at the University of New South Wales in Sydney and the Royal Melbourne Hospital. So, my name is Perminder Sachdev. I'm Professor of Neuropsychiatry at the university. I will be speaking to you later today, but I would first begin by acknowledging the medical people, the Eora Nation, who are the traditional custodians on the land that I speak from, and pay my respect to their elders, past and present. So it's my privilege today to introduce two of our very distinguished speakers. The first speaker will be Professor Amy Brodtmann, who is a highly respected cognitive and stroke neurologist. She works at the Royal Melbourne Hospital and is also professor at the Department of Neuroscience at Monash University. And the second speaker will be Dr. Sam Humphrey, who is a clinical neuropsychologist at the Royal Melbourne Hospital. Recently completed his PhD on post-stroke cognitive impairment. So together they will present to us on cognition in relation to CADASIL, and I will then speak about neuropsychiatric symptoms related to CADASIL as well. A live Q&A will follow the presentations. So please put your questions as they come along into the chat at any time, and they will be discussed after the presentations. The questions will be picked up and perhaps grouped together to give you responses. Now, thank you for attending today. I would like to welcome Professor Amy Brodtmann and then Dr. Humphrey. So Amy first.
Goodness me, I can't multitask at the moment. Good evening, everyone. Thank you very much, Perminder, for the invitation to speak tonight. Thanks to Danit for organising it, and to you all for joining. I'm going to give an overview of cognition and CADASIL, but really talk to you about the pathology and the anatomy, because Sam's going to talk a little bit about what happens. I'm going to give you a little overview of the why this happens and the how, if you like. So firstly, thanks very much. I'll also acknowledge that I work, live and play on the lands of the Wurundjeri Wurrung people, the Kulin Nation. I live just near beautiful Birrarung, the Yarra in Melbourne. I acknowledge elders past, present and emerging, and any First Nations elders viewing this presentation. So you all know that CADASIL is a genetic form of cerebral small vessel disease. So I'll talk about what that is. I suppose we talk about it all the time, but I'm going to use lots of pictures to give you an idea of what this looks like and how this might actually affect cognition, because we often talk about small vessels, but what does it mean in terms of cognition? And then I'll hand over to Sam so he can talk to you about what actually happens. So if you remember, you would have known and had discussions from lots of people that it's associated with migraines, it's associated with cognitive problems, and it's associated with strokes. It's a genetic form of small vessel disease, but just to let you know, there's lots of causes of small vessel disease. We see it super commonly in people who don't have the genetic form. It's caused by high blood pressure and diabetes, and there's lots of different variants associated with it. Most of the common one is the notch, but there's a number of others. And all of these diseases cause small vessels in the brain to thicken and block. And strokes are caused most of the time by blockages to these blood vessels in different locations. And I think the other thing to think about is that strokes can cause acute symptoms when we rush off to hospital and have a code stroke called, with sudden onset of weakness or numbness, but they can cause no symptoms at all. And in fact, a lot of the patients I see with CADASIL will have had a couple of strokes and actually not known about it. So just to do a little overview of what is stroke. When neurologists think about stroke, we think about either bleeds or blockages to the blood vessels. You can get both in CADASIL, and most of the time in neurology, we see blockages of the large arteries. If you've ever felt the pulse on the side of your neck, your carotid artery, that's a large artery, and sometimes we can have a clot or cholesterol that flicks up from the heart and blocks an artery. So that's a cardioembolic stroke. And they're the sort of large and medium sized vessels that can block off. But with CADASIL, we're really talking about these little blood vessels, and I'll show you some more pictures. And these can cause both blockages, causing little strokes, or lacunes in the deep parts of the brain. They can cause tiny strokes we can only see under the microscope, and they can also cause bleeds. So this is a picture on the left is a schematic. On the right is a picture of someone's brain who had a resin or kind of a glue injected into their blood vessels after they died. And you can see these arteries, these same arteries I spoke about, the larger ones coming up into the brain. But you can also see coming off those arteries. These arteries branch off and serve, most of the brain, the surface of the brain, and also really important structures. But all of these tiny little blood vessels are serving those central parts of the brain. Look how small they are as they come into the ventricles of the brain. And they're all coming from the surface of the brain or from the edges, because our brain, is full of connections and full of brain cells, and the blood vessels have to get around that to supply them. So these are those arteries I'm talking about, these small blood vessels that are really vulnerable to a lot of different diseases. The thing about these small vessels is that you think again that image, and this is an image, if you like, where you're being sliced ear to ear and we're looking at both sides of the brain at once, that those blood vessels, those tiny little ones, subserve those central hubs of the brain. Those hubs where all of our processes really plug into when we get information from the outside world that comes up into our spinal cord or through our eyes, our ears, that all plugs into these central structures. I'm not going to use the names of them because they're all sort of dreadful medical names, but those central structures are absolutely essential for human attention, listening to this conversation, not falling asleep and not looking out the window, though you might be doing that. And they're also absolutely essential for us to be able to, allocate attention as well and to stay motivated. So those blood vessels subserve the plugs, the central hubs of our cognition. And if you think this is again a schematic or a cartoon, this is, if you imagine we're being sliced sort of from the front to the back of our head. So we're going right from the frontal lobes to the back. These central hubs are here, and it's all those tiny blood vessels that are affected and then cause things like little strokes, those lacunes, little bleeds, or what we call cerebral microbleeds. We get enlarged perivascular spaces in people with CADASIL, and it's these structures that are really essential. The big other pathology that we see in people with CADASIL is because those blood vessels give supply to the white matter of the brain, the connections of the brain. We see these white matter hyperintensities often at the front and the back of the brain. I've got some MRIs in a moment. And that's a really characteristic pattern or feature that we see in people with CADASIL. Here are some pictures of MRIs of people with CADASIL, and you can see that the images in the middle row, those white matter changes or white matter hyperintensities are white in the particular sequence that we've seen, right at the front of the brain, but also in these central hubs. So this person's got a lot of white matter disease, really affecting all of those connections. The top of the top scans is looking more at little pathologies like those enlarged spaces and also little strokes, those lacunous strokes that are super common in people with CADASIL. And the bottom scans is looking at these microbleeds that are often, again, in these deep areas of the brain, these same areas, because they are affecting those tiny little small blood vessels. So if we think about it, I'm just moving the video around. Sorry if it's annoying. I've said that large and small vessel diseases can impact the brain. In people with CADASIL, it's mainly small. These are the central hubs, and the cognitive pyramid is based on regions that are supplied by these small blood vessels. Things like being motivated and interested to listen or to pay attention, things like actually being able to stay paying attention and swap between tasks. These are all absolutely essential to the rest of the cognitive functions that Sam's going to talk about in a moment. And it's these blood vessels and these areas that are being supplied and potentially affected in CADASIL. And the other thing that we often don't think about enough, I think, when we think about brain thinking and cognition, is that whilst we often talk about grey matter and our grey matter is important, it's these connections, these cables or tracts between the brain that are absolutely essential for our cognition. For adjusted for brain size, we have the longest and largest connections. They're sometimes called fibers or fasciculi in the known universe in the human brain. Our brain is chock full of connections. And these, I've just drawn around them very crudely. I'm no artist. These are the areas that are really affected by those white matter hyperintensities. Again, it's really essential for cognition. And you can imagine that the white matter hyperintensities are the front, the back, and underneath. And these fasciculi, these tracts, these connections are the ones that serve, our visuospatial function, our attention, and our memory. So just to go over this, CADASIL affects the small vessels of the brain. The small vessels provide nutrients to the central hubs of the brain that are really essential for cognitive processing. And small vessel health is absolutely critical for the brain's connections. So now you hear about what's affected and how that's affected with Sam. Thanks a lot.
Thanks, Amy. So I'll just share my slides here. Yeah, so thanks, Amy. So I wanted to talk a little bit more about cognition in CADASIL, and I wanted to start off by explaining a little bit about what we mean by cognition. So in simple terms, cognition refers to our memory and our thinking skills. So we have distinct areas of cognitive function, what we call cognitive domains, and these domains are impacted differently depending on the underlying condition. So what I thought I'd do tonight is have a little bit more of a chat about these cognitive domains, give some examples of everyday difficulties that people report, and also touch on which domains are impacted in CADASIL and which domains might not be impacted so much. So when we think about cognitive domains, we essentially break it down into 6 main domains, those being attention, language, visuospatial abilities, learning and memory, executive functioning, and social cognition. So just on the interest of time, I won't be touching on social cognition this evening, but we'll have a bit more of a chat about the other 5 domains. Wanted to start off with attention. Now, we typically break attention down into sustained attention, selective attention, and divided attention. So sustained attention is our ability to maintain attention over a prolonged period of time, to concentrate for long periods. Selective attention is our ability to maintain attention in the face of distractors, so focus on things and avoid distractions. And divided attention is our ability to attend to 2 tasks at the same time. Working memory is a little bit more complex than attention. It also involves holding information in mind, but also involves manipulating that information in mind. So if you think of something like mental arithmetic, it involves holding the numbers in mind, but also performing those calculations. It's a bit like your mental workspace. So it's a little bit more of a complex process than basic attention. And processing speed is how quickly we can take in, understand, and respond to information. So that's basically our thinking speed. So attention, working memory, and processing speed broadly fall under the domain of attention. People with attentional difficulties might notice difficulties concentrating for long periods. They might become easily distracted. They might report difficulties with mind wandering or zoning out, often appearing like they're daydreaming. They might lose the train of thought, lose track of where they're at in a sentence and forget what they're talking about. They might blank when they enter a room. They can have difficulties holding information in mind. And they also might take a little bit longer to complete everyday tasks if there are difficulties with processing speed. So in CADASIL, we typically find that slow processing speed occurs early in the course of the disease, and this is generally considered to be the most substantial area of cognitive impairment in CADASIL. So if we think back to Amy's slides, we know that small vessels are impacted in CADASIL, and that impacts the white matter, our connections in the brain. And if the connections are affected, that can just slow down the messages throughout the brain and lead to that slowed thinking. So we typically see that early in the course of the disease, as I said, and that can often remain an isolated area of impairment for a number of years. So people just might feel like they're a little bit slower, still able to get things done. And we find on our tests that they still perform well. They just might need a little bit more time to complete tasks. We do start to see some more, excuse me, difficulties with attention and working memory as the disease progresses. And again, that's due to the build-up of the white matter hyperintensities affecting the connections in the brain. So moving on to language, we typically break language down into two main areas, that being expressive language and receptive language. So expressive language is our ability or output of language or our ability to communicate with others. And receptive language is the input of language or our ability to understand and comprehend what others are saying to us. We also talk a lot about verbal fluency, which is our ability to easily and quickly produce words. So, coming up with words on the spot. And it's important to note that language not only includes verbal communication, but non-verbal communication as well, things like pointing and gesturing, and written communication as well. So whether that be handwriting, typing, texting, all those forms of communication fall under the umbrella of language. People that have language problems might report word finding difficulties in day-to-day life, difficulty finding words they want to use in conversation, feeling like a word might be on the tip of their tongue and just can't quite get it out. Other things like comprehending information or following instructions might be difficult, or things like changing in reading and writing abilities as well. So we typically find in CADASIL that language abilities are typically preserved. We might see some difficulties with verbal fluency. We typically consider this to be secondary to slow processing speed. So we think, if we thinking verbal fluency is how quickly you can produce language. If there's slowness in the speed of thinking, that's going to affect verbal fluency as well. So we typically, as I said, think that that's more of a processing speed problem than a language problem per se. Moving on to visuospatial abilities, we can break this down into visuoperceptual abilities and visuoconstructual abilities. So visuoperception is our ability to recognize objects based on their form or pattern, color. And visuoconstruction is the coordination of our fine motor skills with our spatial abilities, so manipulating visual information in space. People with visuospatial problems might have difficulty recognizing objects or familiar faces. They can have difficulties finding objects in plain sight, particularly in cluttered environments. They might have difficulty distinguishing between objects, navigation problems or change in sense of direction. Difficulties with depth perception, perhaps bumping into furniture or door frames, knocking things over, sort of having trouble judging the distance between things. There might be driving difficulties as well, perhaps difficulties parking or reversing, getting a bit close to other cars and having some dents and scratches. Again, we think visuospatial abilities are fairly well preserved in CADASIL. There is some research to suggest that the visuospatial abilities can occur later in the course of the disease, but we don't traditionally think of this as something that we see early on or as a major part of the disease. Now, learning and memory difficulties are probably the number one thing that people report in clinic. Often people come in to see us and they report concerns about their memory, but it's important to consider that learning and memory go hand in hand. And when we think about learning and memory, we break it down into three stages. Those are encoding, storage, and retrieval. So encoding is our ability to take in and learn new information. Storage is ability to maintain that information in the brain, and retrieval is accessing and recalling that information when required at a later date. So memory and learning basically involves those three stages, but I also wanted to touch on the importance of attention as well. So if we think about in our day-to-day environment, we're hearing lots of things, we're seeing lots of things, and we're not remembering everything that we hear and see. We have to pay attention to things for us to be able to learn those things. If we're able to pay sufficient enough attention, that information be encoded, goes into storage, and we can access that information later on. But if we have difficulties with attention, that can interrupt this memory process. And we might see that information isn't encoded properly, then it's not stored. And when you can go to retrieve that information later on and you find that it's not there, and it can often feel like a forgetting problem, you're not able to grasp that information, but it's that we haven't learnt it in the first place. So we often see encoding difficulties or difficulties learning new information are secondary to difficulties with attention, and that can often feel like a forgetting problem. But when we're able to perform some of our cognitive tests, we can break this down a little bit further. So people with learning and memory difficulties might lose items, misplace things, they might forget details from conversation, they can be repetitive and say the same things over and over again, particularly within a few hours. They might have difficulty remembering recent events, things they've done recently, difficulty with names and appointments as well. So in CADASIL, we find that memory is typically preserved, now particularly memory storage. Now, encoding and retrieval difficulties can be seen in CADASIL, particularly as the disease progresses. And again, we think this is mainly secondary to slow processing speed and the reduced attention and working memory. So if we've got slowness in the thinking, we can't concentrate for as well as you might have in the past, that can really impact the amount of information we can take in and later remember. But we do find that people with CADASIL benefit greatly from prompts and cues, so that the information isn't completely lost, and if someone gives them a little reminder, that can be really helpful. Now, the final cognitive domain I wanted to touch on is executive functioning. Now, this is our higher order and more difficult or complex thinking skills, involves things like planning and organization, problem solving, reasoning through things in a logical way, flexible thinking, so switching between different concepts, and response inhibition as well, so inhibiting automatic responses and resisting impulses. So people with executive function problems might have difficulty planning and organising events and holidays. They might have trouble maintaining complex hobbies and interests, difficulty using household appliances or learning how to use new technology, particularly when there's multiple steps involved. They might act impulsively or say or do things without thinking. So we tend to see in the intermediate stages of the disease that executive functioning difficulties become evident in CADASIL, and this can become increasingly impacted as the disease progresses. There are quite a lot of different areas of executive function, and we typically see a variable pattern of executive dysfunction between individuals. So some people might have reasoning and problem-solving difficulties, other people might have more difficulties with impulsiveness and things like that, and this tends to vary a little bit between individuals. So finally, just to summarise the cognitive changes that we'd typically see in CADASIL, we find that slow processing speed is observed early in the course of the disease and is the most prominent feature. Attention, working memory and executive function difficulties become more evident as the disease progresses. This can have secondary impacts on things like verbal fluency and memory encoding and retrieval. But we typically see that things like language, visuospatial abilities, and memory storage are preserved in CADASIL, and they're not areas that we typically see where people might have difficulties. So I'll leave it there and hand it back over to Perminder.
Thank you very much, Amy and Sam. That was highly informative, very well presented. So thank you again. I'll share my slides now. Okay, so I'm going to speak to you about neuropsychiatric symptoms related to CADASIL. I just disclose my conflicts. Now, you've been told about migraine, you've been told about cognitive disturbance, you've been told about stroke. These are the commonly recognized features of CADASIL. But then there are other features that sometimes you see, and I think it's important to recognize these as well, because firstly, you tend to then understand why some of these other symptoms are happening, and also perhaps something can be done about them in terms of both treatment as well as prevention. Let's start off with this very famous person from the 19th century, one of the most famous philosophers of the 19th century, Friedrich Nietzsche. And Friedrich Nietzsche is well known for his classic books, The Will to Power. Of course, he's the one who declared that God was dead. and has influenced a whole generation, or many generations of philosophers and writers, including someone as famous as Sigmund Freud. Now, but when we look at his history, his clinical history, he developed migraines in adolescence, migraines with aura. And then at age 28, he developed major depression, from which he recovered after a few months. And then a few years later, he developed manic symptoms. He was ebullient, he was grandiose. In fact, it seems that he might have had grandiose delusions at that time as well. He thought that he was greater than the emperor. And he, in fact, within a few months, he wrote these 3 books or 4 books. And some of these books are still classics. And at age 45, he developed mild cognitive symptoms, also developed some behavioral symptoms. He became irritable, he became somewhat amotivated. He stopped writing at that stage and became aggressive towards people. And there was noted that he had a personality change. And age 53, he had what appears to have been a stroke, although there are some features described of him developing weakness in his arm and leg. And at 55, he had a massive stroke and died. And some medical historians have gone back and said perhaps Nietzsche had CADASIL. Of course, we didn't have any test for CADASIL at that time. We didn't really recognize CADASIL, and there was no genetic testing available in those days. But it does highlight that there are other features, possibly of CADASIL, that we should be aware of. And if you actually look at this review, it goes back some years now, that if you look at the common symptoms, of course, migraine with aura, recurrent ischemic strokes, and cognitive change. But we also recognize that there are other features like mood disturbance and apathy. And we'll be talking about the various kinds of mood disturbance that you can see in some individuals with CADASIL, but sometimes that may be a major feature of the presentation as well. Now, I just wanted to very quickly say, why should this happen? Why should these people develop neuropsychiatric symptoms? And of course, Amy has helped me already by actually giving you the background of small vessel disease and how small vessel disease affects the white matter in the brain. As you know, the brain has a gray matter, which has the neurons, and these white matter, which are the tracts, which link different parts of the brain, because the brain basically is a network, or a number of different networks working together. And for any action or any thought or any behavior, a network has to be activated, which means that there are neurons that are activated, and then they are talking to other neurons through these networks. And if you disrupt these networks, then by injuring the tracts which convey the information, then you will see dysfunction in that particular ability. And there are, and these white matter lesions or changes in the white matter that Amy was talking about are the perfect candidates for disrupting some of these networks. And Amy also mentioned that it's not just the white matter lesions, but other lesions. These are little lacunes, little tiny holes. A lagoon essentially means a lake, but these are tiny holes, about 3 to 15 millimeter in width, that are a result of infarctions or little hemorrhages, or dilated spaces around the arteries, or small bleeds in the brain, which lead to disruption of these networks that are represented here. And when we actually look at the networks in the brain, a number of different circuits have been identified. And some of these circuits have been referred to as the cortico-subcortical circuits. So what happens is that the cortex, which is where the neurons are, they have connections, axons, which go down to what we call the subcortical regions. These are clumps of neurons which sit inside in the middle of the brain. These are the basal ganglia. And then they are connected to another region which looks at the stem of the brain, which prominent structure called the thalamus. And thalamus has neurons which connect back to the cortex. So it forms a loop, really. And these have been referred to as a cortico-subcortical circuits. And there are several different circuits in the brain. And we link these circuits to different functions, both cognition as well as emotion and behavior. And three circuits that are very important. And I will just show you this. One circuit that actually starts from this front of the brain, the lateral side of the brain, the side of the frontal lobe, which is called the dorsolateral prefrontal cortex, which again connects to the deeper basal ganglia or the caudate nucleus, basal ganglia, and then the thalamus. Then if you look at underneath the frontal lobe, this is called the orbitofrontal cortex. And especially this part of the orbitofrontal cortex is sitting just above the eyeballs in the brain. This is serving a different function when connecting to the basal ganglia. And then there is, if you actually look at if you slice the brain in the middle, say from front to back, and you look at the inner side of one lobe, the brain, see this region of the brain is called the anterior cingulate. And this is connected to the basal ganglia also. This has another circuit. I'm telling you these circuits because these have slightly different functions in terms of how they support emotion and behavior. And depending on which circuits are predominantly affected, different kinds of changes can occur in the person's functioning, the person's emotion, cognition, and behavior. So actually, when you look at the kinds of symptoms that you see, neuropsychiatric symptoms that you see, you can see here I've listed some of them. It's irritability, depression, apathy, aggression, and anxiety. And all of these have been described. And here, this is one study. This is actually a Korean study, which looked at the age of onset in their sample, about 80 patients with CADASIL, at different ages at which some of these symptoms appeared. But usually, so you're looking at the 40s and 50s when you see these symptoms. Although some of them, sometimes they may occur earlier, but usually it's in the 40s and 50s that you tend to see these changes. Some of these are often described as personality change rather than any specific symptom per se. But depression is one that is particularly prominent, and apathy is another one that's particularly prominent. And I'll briefly discuss those two today. So in terms of depression, as you know, depression can be a significant illness and cause a significant degree of morbidity, even mortality. Now, this is a patient, 56-year-old patient, CADASIL, who was suffering from depression. And she also had some cognitive problems, like she had executive dysfunction, the kind of changes that Sam was describing earlier. And she had extensive white matter hyperintensity. So you can see that this area of the brain, the white matter, shouldn't be so white. It should actually be much darker in color. And you can see a few holes here, some lacunes as well. So it shows that there is extensive white matter. So a lot of disruption of her cortical subcortical circuits, and possibly explains why she developed depression. As I said earlier, we described about 20% of patients, so 1 in 5 patients with CADASIL, but sometimes some series is higher as well, and that's for major depression. And then some people will develop mild depression. Now, the other coin to depression sometimes is mania. And development of mania is uncommon, but it has been reported. And usually the patient with depression will present with low mood, with poor sleep, poor appetite, lack of motivation, lack of drive, often loss of weight, negative cognition. They start thinking negatively. They become pessimistic for the future. They might become hopeless. In severe cases, they even might think that life is not worth living. And often they're unable to work, unable to concentrate. So that's the kind of picture that you see in these patients. The majority of the patients, I've seen a few patients like that, and usually they were in the 50s and 60s. And the presentation was very much like what we see in major depression, with significant what we call melancholic features, like they were physiological features. They were slowed in their activity, in their thinking, and they had loss of interest, loss of pleasure, and they thought that nothing actually gave them joy anymore. That's the kind of presentation that they had. And often it is associated with significant fatigue as well. And they may also complain of concentration difficulties, sometimes memory problems as well. And there's been a lot of debate in the literature as to whether it is the changes in the brain, the small vessel disease that is causing this depression, or is it because of the fact that they have CADASIL, or they might have had a stroke, and there's a lot of stress because of the medical problems that this has created, or some cognitive difficulties that this has created. So it's a reaction to that. So this is this tension, of course, generally in neuropsychiatry as to whether it's biology or psychology that is causing it. But I think that's really not a very useful binary distinction that one should draw, because usually there is a biology, a vulnerability. And I think what the small vessel disease is doing is increasing that vulnerability and making them more vulnerable to develop depression if they face psychological stress or some other financial or family stress or any kind. But some people actually have argued that it is purely the vascular pathology that is leading to brain changes that is causing this depression. And it's been referred to as vascular depression by these people as well. But I think the more important point is, what are the implications of this? Now, some people have tried to see, okay, is this depression related to the small vessel disease? If you look at white matter lesions and lacunes, yes, the more white matter hyperintensities you have, the more likely that the depression will be there. So there is some relationship to the presence of small vessel disease in these people. So what about treating depression in them? So unfortunately, see, one of the things is that we don't have any good treatment studies in CADASIL per se, because the numbers are not so large in any group. So, but we have, of course, a lot of evidence for treatment of depression generally, and also treatment of depression in stroke patients. And we use the same drugs as we would generally use in for major depression. So there are the commonly used SSRIs, the serotonin specific reuptake inhibitors. You might have heard of drugs like fluoxetine or sertraline, etc. Then there are other drugs we can use as well. And often patients do respond to medication if they're given an adequate dose. And usually they are able to tolerate the medication. There are some drugs that may have more side effects than others in these people. So that's one thing that you would have to take into consideration. So basically, I think the important thing is to see a doctor, speak to your GP if these symptoms are present, because something can be done about that. It can be treated. And sometimes you may need trials of medication before you find the right one for yourself. And I think that's really one of the things that, so one has to be patient in treating medication, sometimes treating depression. And sometimes we may have to use a combination of medication as well. So that's something that a general physician and, if necessary, a psychiatrist may need to be involved in finding the right treatment for you. But at the same time, it's important to look at any other possible interventions that may be helpful. For example, as you know, with major depression, we use behavioral interventions. We also use psychological interventions. And cognitive behavioral psychotherapy is commonly recommended. And we would probably recommend that for depression, CADASIL as well. Although we know that there is a strong biological component to this, but that doesn't preclude you using psychological therapies in depression. In severe cases, ECT or electroconvulsive treatment may be useful as well. That is reserved for only the patients who are very severe, not responding to drug treatment and psychological interventions, and who are at increased risk. But it is important to remember that sometimes the presence of these lesions in the brain may increase the vulnerability of the brain and also the response to treatment. The other syndrome to remember is apathy. Now, apathy differs from depression in that apathy basically is reduced motivation and disengagement from different aspects of life. So these people do not want to talk to people, they don't want to engage with anyone, they want to isolate themselves, and they have a kind of a blunting of their emotion. They don't show that emotion. Whereas depression is actually an exaggeration of negative emotions. You feel strongly negative about things, or you're distressed when you're depressed. Whereas these apathetic people are not showing much emotion. And this is actually quite common in patients, some patients in the later stages, especially of CADASIL. And important to remember that firstly, it needs to be separated or distinguished from depression, although sometimes the two may overlap. And this is also related to, we think, to white matter change in the brain. In fact, Professor Chris Levi from Newcastle looked at some of his patients with long-standing CADASIL, and many of them had apathy. And he actually wanted to do a trial because often, if they don't have depression, that antidepressant treatment will not work. And he wanted to do a trial of a drug called modafinil, which we use for narcolepsy. And it has a stimulant property. And sometimes stimulants have been used, like dexamphetamine or methylphenidate have been used for apathy, although there have been no good trials of these drugs. So they're kind of off-label usage to see whether they help. The other symptom that is quite common is fatigue. And this basically is patients say that, look, they feel weary, they lack energy and on a daily basis, and it limits their functioning, limits their interaction with people, limits their ability to work adequately. And we know that this fatigue is much more common in CADASIL patients. And this has an association with apathy and depression as well, but we think it's distinct because many patients with fatigue do not have depression. And it doesn't seem to have good relationship to the small vessel disease we have been talking about either. And this can be difficult to manage again, although we recommend more behavioral strategies, regular exercise to deal with this, a good rehab plan to deal with fatigue, and less reliance on medication, especially if there's no associated depression. There is, as I said, there's some overlap between fatigue and depression and cognition. This is in between, but there are patients who will have one or the other and not all of them. And so for apathy and fatigue, as I said, treat depression if present. We can try other drugs, but certainly you need care of a specialist, I think, if you are going to do this. And physical exercise. And of course, I think the families need to be aware that some of this behavior is driven by the disease and it's not just laziness on the part of the individual. And then, of course, irritability and aggression can happen. And there are various reasons for that. Sometimes it may be mild depression that's causing it. Sometimes it's awareness of cognitive change that makes a person irritable. But sometimes it will be just that the change in the brain causes more impulsivity. So these people are unable to tolerate anything readily. and sometimes anxiety. Anxiety, of course, is fed by the fact, of course, that if you know that you have a genetic disease that could possibly lead to ill health. It doesn't, of course, always many people live long, healthy lives with CADASIL, but that can cause anxiety as well. But sometimes the changes in the brain can lead to anxiety. So I've given you a list of symptoms that can happen, but of course, not everyone has these symptoms. And I think the important thing is to be aware that this can happen, that these symptoms can be managed in many cases to improve quality of life. If you're not completely cured them, you can actually manage them, treat them to some extent. And of course, we also need to do more research to find better treatments for them in the future. So I thank you for your attention, and put this up if you wanted to access our first webinar and also to participate in the AusCADASIL study. Of course, Danit Saks, who you can see, is the coordinator of this. And so you'll be talking to her if you ring up or send her this email. Thank you very much. Stop sharing.
Thanks, Perminder. There's a couple questions in the chat.
Yeah, Q&A, I think, has got quite a few questions. Yeah. So I'll start with the first question. It's from Russell. Is there a typical or predictable pattern of when cognitive symptoms manifest in CADASIL relative to other symptoms like the migraines? Sam, Amy, would you?
Sam can also respond. So there is no typical pattern. I think that's the thing about CADASIL, that is, everyone has a different way of responding. We know that people in general, the migraines can start in, the normal time, 20s and 30s, and then people start to notice their cognitive symptoms in their 30s and 40s. But everyone's so different. I've seen people who've got MRI changes and they've only just come in because of the family history, and they're cognitively fine in their 50s and 60s. And I've seen people in their 30s who've got almost no change in their brains and, complaining of problems with their memory. So I think that there is no pattern. Everyone is different in my experience.
Thanks. Sam, was there anything you want to add?
No, I agree entirely with Amy. I think it's very variable.
Thanks. So, Amy, again for you, from Patrick, in relation to the tracts, what do you think is happening? Is it demyelination, or are there other changes in the migraine?
Yeah, I mean, there is certainly demyelination is a component, but it's not the demyelination that we classically see in the condition that we often think of with demyelination in the brain is multiple sclerosis. It's different to that. CADASIL's an astrocytopathy, terrible word, so it affects the astrocytes in the brain. The astrocytes are kind of the support staff of the brain. They're the help. They help with synapses, which are the little tiny connections between nerve cells. They help with the metabolism of the brain. They help clean up afterwards. So they help with cleaning up byproducts of the neurotransmitters. So they really are a very central kind of support for the brain. And we know that when the astrocytes don't work well, then the myelin doesn't turn over the same way and it doesn't get cleaned up. And obviously there is the super added effect of a lack of oxygen and blood supply because of that. Small vessels are blocking off because of the deposits in the blood vessels. So the pathology is complex.
Thanks very much. So the next question, I guess, again from Patrick. So he says that I use acceptance and commitment therapy in dealing with CADASIL. So perhaps I can respond to that. Yes, see, if you're dealing with any major stressor, and having a disease is a major stressor that you have to live with, then I think certainly acceptance and commitment therapy is a good way to go. and often psychologists, clinical psychologists would recommend it. My only recommendation is that it is usually a good idea to start any treatment with the help of a professional. And I mean, of course, there are many online modules available or interventions available. But if you can, I think best to start off, and then you may want to continue treatment with by yourself once you complete those sessions. And most people can actually access a mental health plan if necessary to start a treatment, get referred to a clinical psychologist who does the right sort of treatment. They'll find the best treatment for you that might be suitable for you, and then continue with that. Generally, that's the recommendation that I would have. The other question from Paul O'Brien is, does increased sleep help with fatigue? Now, now this is a tricky one. I know people who complain of fatigue or suffer from fatigue, excessive fatigue, tend to sleep or lie in bed a lot. They must sleep intermittently. They don't always have good quality sleep all the time. Certainly, you need adequate sleep. Yeah, if you don't get adequate sleep, then you do feel fatigued. Yeah, but I think excessive sleep is not helpful either. That can actually also lead to fatigue. So my recommendation generally is to normalize your day-night rhythm, to try to get adequate sleep at night. But you have to have good physical activity, especially in the morning. Maybe not too much physical activity late in the evening, but have good exercise during the day, enough exercise, and then have regularize your sleep. And if there is a sleep disturbance, to perhaps also look into that, get a medical consultation to see you might not have a sleep disorder. But sleeping excessively is not an answer to fatigue, generally speaking. Okay, so the other question, maybe Amy, you want to take this. Is there a difference between CADASIL and CADASIL in relation to the symptoms described here tonight? So, William has been diagnosed with CADASIL.
Right. Yeah, from our perspective, obviously one's autosomal dominant, one's autosomal recessive. So sometimes it's harder to work out that someone has CADASIL because they've got a different family history, because it doesn't run in families the same way. CADASIL, the patients that we've seen have got, in general, I think the symptoms are a little bit milder. The white matter pathology is in a slightly different pattern of where it is deposited, and so they have slightly different symptoms. The literature would also suggest that it is probably it's a more slowly progressive disease, and that people can have the onset of symptoms when they're older. I haven't seen, a huge number of people with CADASIL, but the ones that I've seen don't seem to have migraines as a dominant feature either.
But it's less well studied because the cases are less common. Yeah, of course. Yeah. Now, relationship between CADASIL and coronary artery disease. Some studies are supporting this existence. This is a phenomenon. Someone wants to know, do you know of any relationship with coronary artery disease?
There are some studies, and we've certainly seen patients. There is, I'd have to say there's not a lot of data, but there's a number of case series there now where they're saying that, there's a small vessel disease in the heart, as well as in the kidney. I've seen some case reports. I think that it is accepted that people with CADASIL can have heart problems and arrhythmias as well. It's usually not blockages to the blood vessels that we'd see that, you need to go off and have an angiogram. It's often this more small vessel disease. So, I mean, I'm certainly no expert on that. I always say I'm a neurologist. I only do brains, but I think that there have been some case reports. Yeah.
Yeah, but it's not a major issue generally with coronary artery disease.
No, coronary artery disease, no, but small vessel disease of the heart.
Yeah. Now, I think this question has come up again twice, really, is what about early treatment? Is there anything to slow down or stabilize CADASIL? What can we do to prevent progression? Maybe you can take that first, and then I might add something if.
So we don't have a medication that's a disease-modifying therapy yet. I'd have to say there's very, very active groups, particularly internationally. The Cure CADASIL group is hugely active. We recommend all the things that are good for brain health generally. So eating a great diet, making sure you don't have high blood pressure as well, and making sure that you've got a sense of joy and a sense of purpose in what you're doing. Lots and lots of physical exercise. So all the pillars of heart health and brain health are the same. So that's what we recommend. I'd have to say that though this is a hugely active area. And that the foundations such as Cure CADASIL, etc., have got a lot of drugs in the pipeline right now. There are trials being run as we speak.
No, thank you. I think that's a very important point to make, really, is that CADASIL certainly is a strong risk factor, but not the only risk factor for small vessel disease. There are many other risk factors which are modifiable, which are controllable. And high blood pressure and diabetes and smoking are the big ones, and physical inactivity, perhaps obesity, maybe others. So I think attending to those, and if you have CADASIL, then of course, if you look at your general health and keep your general health in good nick through your life, really, I think that's really important. And that can certainly serve you very well. We do that for other disorders as well. So it's not really that nothing can be done. Yeah, there's much that one can do really to preserve brain health into late life. Yeah. I think that's Danit, that's all we have. I think we've covered all the questions.
Yeah, and spot on at 7 p.m. So perfect timing to all.
Perfect timing.
So I might just actually say thank you to all the presenters because I think those were all very, very informative talks. If anybody wanted to reach out with any further questions, you can always reach us at the AusCADASIL email. You can find it on the website. You can send me an email, call me, whatever you need to do. And if you do have any more questions about participating in this study as well, please do get in touch. We're now doing assessments in Sydney, Newcastle, and Melbourne. And hopefully we'll be doing assessments in Brisbane and Perth very soon. So thank you all very much for coming.
Thank you. And also want to say if you have suggestions for future webinars, any topics that you'd like to cover, please let us know.
Yep.
Thank you all. And thank you again, Amy, Sam, and Danit. Bye-bye.
Thanks, Perminder. Thanks, Sam.
everyone.
Thanks, Anna, for organising.
Bye-bye.
See you later. Have a good evening.